Welcome to this Boehringer Ingelheim Symposium. It's a great honor for me to welcome Scott Mcdougall as a speaker. He will give you an overview of the use of NSAID in mastitis. And I think the timing is absolutely perfect, being in Sapporo this week for the World Buiatrics Conference, because we have an announcement, a big announcement to make for Medacam in Japan. We just got a new claim. And guess what? It's a claim on mastitis. So I would like Kerry, our colleague from Boehringer Ingelheim, Japan, to say a few words about that and tell you about the story behind it.
今日は皆さんベーリンガーのランチョンセミナーにお越しくださいましてどうもありがとうございます。今日のトピックは NSAID と、乳房炎ということですけれども、私どものメタカムが乳房炎の効能を、今月追加しましたので、一応お知らせさせていただきたいと思います。今日はニュージーランドから、スコット、面白い話聞けると思いますので、最後まで、ごゆっくり勉強してください。よろしくお願いします。
Konnichiwa and good afternoon, and I thank you all for giving up your lunchtime to come and listen to me speak. What I hope to be able to show you is that the use of non-steroidal anti-inflammatories in mastitis is not only the right thing to do for the cow in terms of cow welfare, in terms of cow comfort and cow health, but I will also try and demonstrate to you that effective treatment of mastitis has other benefits such as improved cow fertility and hence economic benefits for the farmer. So let's start. Everyone in this room, I'm sure, is very familiar with the signs of clinical mastitis. So the heat, the redness, the swelling and the pain, and the loss of production, loss of function. And in fact, these clinical signs were first described nearly 2,000 years ago. So there is nothing new in this. However, what is new is our understanding at a physiological and at an immune level of what is actually happening in cases of either trauma or infection. So we know now that where there is tissue damage associated with bacterial infection or with trauma, there's a whole series of responses from the animal. So we see inflow of inflammatory mediators, pain mediators, clotting factors, and we see inflow of white cells, leukocytes, so neutrophils and monocytes and macrophages. And these cells in turn release factors such as cytokines and prostaglandins which drive the inflammatory response that we're all familiar with. Now, inflammation is perfectly normal. It is the normal body's response to trauma, to damage, to tissue. And so we rely on the immune response, the inflammatory response, to ensure that the bacteria or the trauma is dealt with effectively. However, what we now know is that in some cases, the inflammatory response is excessive or prolonged. And in these cases, we get a release of reactive oxygen species which cause tissue damage. We may get prolonged release of cytokines and ongoing change and damage to tissue. So in some cases, excessive inflammation has negative effects on tissue, including the mammary gland. And just to illustrate in a little bit more detail some of the tissue responses. So this is work from Doug Bannerman in the United States where he infused the bacteria Klebsiella pneumoniae and then measured the cytokines in milk. And what you can see very clearly in the open circles here is the massive increase in tumour necrosis factor alpha, interleukin-1 beta, interleukin-12, interferon gamma, and IL-10. So these pro-inflammatory cytokines are driving an inflammatory response, the heat and the swelling within the mammary gland. Another pathway that's activated by trauma or bacterial invasion is that of prostaglandin synthesis. So free fatty acids, and particularly arachidonic acid in cell walls and in tissue, is converted to prostanoids and then prostaglandins by the enzyme cyclooxygenase. And in fact, there are all sorts of these other vasoactive compounds that are produced when there is tissue trauma or infection. And there are also, as we know, systemic effects. When we get tissue trauma or infection, we start seeing things like increased rectal temperature, increased heart rate, and depression of rumen contraction. So clearly effects above and beyond just the local effects in the mammary gland. And of course, we know that we see depression of production. So there is a functional damage to the mammary gland, and we see, for example, reductions of, in this case, 30% in milk yield following a naturally acquired infection with Staph aureus. And I could put up many different bacteria species that would show the same sort of pattern. And more recently, this idea that there is inflammatory change at a systemic level, including activation of a whole series of compounds at the liver level, has been put forward. So mastitis, along with things like metritis, leaky gut syndrome, oxidative stress and social stress, and so on, are mediated through changes in the liver, release of acute phase proteins, with all sorts of systemic negative effects. So how does the cow respond? What does the cow do in the face of infection and inflammation? It tries to restore normal function. It tries to return back to its normal state. So homeostasis is preserved. And there's a whole series of changes that go on at the neural level, at the endocrine level, hematological level, so changes in white cells, immune function, which we've talked about, metabolic changes, and in fact, behaviour changes in the animal. And this idea that animals adapt to disease, they show sickness behaviour to try and preserve their bodies. So we see this loss of appetite, reduced water intake, changes in temperature, decreased social activity, so they isolate themselves, sleep more, reduced grooming behaviour, and in some situations they maladjust. They actually go into effectively what we would perhaps call depression and non-enjoyment of life. So these are behaviours that cows demonstrate under stress. I've focused on the mammary gland, mastitis. I've focused on the systemic effects of inflammation, but what we also have known for more than 20 years is that mastitis has negative effect on cow fertility. So, for example, some early work in the United States showed that the interval between one heat or one breeding and the next heat or breeding was altered by mastitis, either shortened or lengthened. Very clear evidence that mastitis cases are associated with reduced conception rate, with increased embryo loss or increased abortion rate, and taken together this means that the interval from calving to conception is delayed, and we require more insemination, more services to actually achieve pregnancy amongst those animals that do ultimately get pregnant. And there are many papers from around the world saying the same thing. So mastitis has in some cases, very severe negative effect on cow fertility. What has become apparent more recently is that subclinical mastitis also has some negative effects on fertility. So here's some data from animals that were clinically normal, no evidence of clinical disease, but had elevated somatic cell count. And in these animals, there was an increased interval from calving to first breeding, from calving to conception, increased number of services required per conception, and increased abortion risk. And again, these are animals with no clinical disease. So visually, they look fine, but there's all these negative effects here. And there are a number of mechanisms by which mastitis may negatively impact on fertility. The first is the very obvious one. As I showed you earlier, with tissue damage or bacterial invasion, we get production of prostaglandins and a whole series of them. But one of the prostaglandins released by the mammary gland and other tissues is prostaglandin F2 alpha. And as we all know, prostaglandin F2 alpha causes luteolysis in the dairy cow, and in the dairy cow, the embryo survival is dependent on a functional corpus luteum. So if we get luteolysis, we lose the embryo. And this is some quite early work, nearly 30 years old, showing the elevation in prostaglandin concentrations following, in this case, a LPS challenge model, and a decline in progesterone. So demonstrating that endotoxins, LPS in this case, will cause release of prostaglandin F2 alpha and hence embryo loss. So this mechanism is very clear. There's other work showing that the effects are not just at the corpus luteum level. So this is some Israeli work from about 10 years ago, where what they did was synchronize some cows, and then just at the time the cows started expressing estrus, they injected them either with saline or with LPS. And in the saline cows, 100% of them went on and had a luteinizing hormone surge and ovulated in the normal time frame. But for the animals infused with LPS, 7 of them, or 33% of them, had a delayed LH surge, and in some cases, no LH surge at all, and hence didn't ovulate. So graphically, this is the LH concentration up the y-axis and hours from onset of estrus on the x-axis. And what I want you to focus on here is these animals that were injected with LPS, and you can see in some cases the luteinizing hormone surge was occurring 2 days after onset of estrus, compared to virtually at the time of estrus for the normal animals. And in fact, there are animals that had no LH surge at all, so they never ovulated, despite starting to show the signs of estrus. So very clear evidence, again, that LPS can abolish luteinizing hormone surges, so having effects not just at the ovary or uterine level, but at the central nervous system level. I've focused a lot on LPS, so the model for gram-negative mastitis infection. But much of what I've just said is also true for gram-positive infection. So again, some nice work from the US, where they used a model of artificially infecting cows with the gram-positive bacteria, Streptococcus tuberous, prior to the expected time of ovulation. And what these guys showed was a reduced LH pulse frequency, a reduced peripheral concentration of estradiol, so less likely to show behavioural estrus, and ovulation only occurred in 4 of the 12 challenged animals compared to 12 out of the 12 control animals. So a 2/3 reduction in ovulation rate when an animal became infected with the gram-positive pathogen Strep tuberous about the time of estrus and ovulation. So this is not just a gram-negative effect, but also gram-positive bacteria can have negative effects on reproduction as well. So returning back to the prostaglandin story. So what I now want to focus is on the prostaglandin release. And as I said before, it's these free fatty acids, arachidonic acid, that's converted by this enzyme cyclooxygenase down to prostanoids and the various prostaglandins. And it's this cyclooxygenase, or COX enzyme, that is a key enzyme in this process. And if we are able to block this enzyme, and this is effectively what the non-steroidal anti-inflammatories do, they block the effect of this enzyme, then we reduce the concentrations and release of the prostaglandins. Now, we now know that there are actually two forms of this enzyme, Cox1 and Cox2. Cox1 is expressed in most tissues of the body, and it's expressed constitutively. So basically it's being expressed at all times, and it has an important role for example, in maintaining the gastrointestinal mucosal integrity. It aids in platelet aggregation, so in the clotting mechanism, and it maintains renal blood flow. So it has an important normal physiological role. But COX2 is inducible, so in a normal animal it is not expressed very much at all, but once there is tissue trauma, in bacterial invasion, this enzyme is upregulated, so you get more prostaglandin production. And the important point here is that most of the therapeutic effects of the non-steroidal anti-inflammatories probably are being mediated via inhibition of COX2 rather than COX1. But we also need to say that there are effects of non-steroidal anti-inflammatories via different pathways than just inhibition of COX. So there's a whole series of things that non-steroidals do, such as PG receptor blockade, scavenging free radicals, anti-bradykinin effects, so vasoactive compounds, and inhibition of a series of these cytokines or chemokines. Non-steroidals can be very crudely split into two classes. There are those that inhibit both COX1 and COX2, so they're so-called non-specific non-steroidal anti-inflammatories, so drugs such as aspirin, flunixin, ketoprofen, phenylbutazone fall into this class. And then there are non-steroidals that are more specific in terms of inhibiting COX2, so COX2 preferential, such as carprofen and meloxicam or Metacam. Now, by blocking this enzyme and reducing prostaglandin production, we are having anti-inflammatory effects, we're having analgesic effects, we're also having anti-hyperalgesic effects. So it's a fancy way of saying that we're reducing pain sensitivity, and of course we're having antipyretic effects. We're managing temperature. And just to illustrate some of those points, here is some data from, in this case, Metacam, being injected into animals that have been, again, challenged with LPS. And in this case, the udder was being scored for edema on a 1 to 4 scale. And what you can see is that the animals treated with meloxicam here in blue have a lower udder edema score 3 and 6 hours after LPS infusion. So reducing the severity of the udder edema occurring here. The same group tried to, or developed a technique for measuring pain, and this is what's called an algometer. So basically there's a metal plate here that is attached to a pressure transducer, and what you do is you push into, in this case, a mammary gland that's been infused with LPS. And when the animal responds, she kicks or moves, the maximum pressure that the animal will withstand is being recorded on this unit. And by comparing the pressure that you put on an uninfected gland with the pressure that you put on the infected gland, you can see if there's a change in the sensitivity, and this is interpreted as pain, amongst infected and uninfected glands. So what they did in this study, again using an LPS infusion model, they compared the pressure in glands that were not treated with Metacam, so these are control glands, and what you can see is the difference in pressure between the control gland and the treated gland increased in the in the control gland. So what this means is effectively there was less pressure required on the LPS gland before the cow reacted compared to the control gland where no meloxicam was given. But if Metacam, meloxicam was given, in fact there was no difference in the pressure on the control side or the infected, or in this case in LPS infused side. So this is interpreted as saying that the meloxicam has blunted the pain response. The animal is not feeling more pain in the infused gland, whereas in the control animals, they were feeling more pain. They flinched at a lower pressure. As we know, animals that are under stress have elevated heart rate. And so if an animal has got mastitis or is infused with LPS, we see a 20 or 30% increase in heart rate over a relatively short period of time. And if we inject, in this case, non-steroidal flunixin here in the black squares, we can see that the rise in heart rate is more or less prevented. Interestingly enough, the steroid, isoflupredone, was somewhere in the middle. So in fact, flunixin was better at managing heart rate than the steroids were in this particular study. The other effect we see with infection or inflammation is changes in the rumination rate. So again, the Canadian group looked at the duration of rumination over a 2-hour time frame. So in healthy, happy cows, they were ruminating for about 40 minutes out of 120 minutes. So about a third of the time they were ruminating. But when they infused LPS, what you can see is this very significant decline in the rumination duration. And this group here in the open squares were not treated with a non-steroidal. So these are the control cows, if you like. And then the animals treated with flunixin here in the solid squares rebounded more quickly. So they recovered their rumination rate more quickly where they were given flunixin relative to the control cows given sodium chloride. And of course, we know that non-steroidals will reduce temperature. So the top panel here is flunixin, so temperature up the y-axis, time across the x-axis, and animals treated with flunixin in the bottom line here had very little change in temperature relative to control cows. And similarly with meloxicam, the temperature increase was significantly less in the meloxicam-treated cows than the control cows. So an antipyretic effect going on here. And so there's plenty of data, I believe, over nearly 30 years now showing that use of non-steroidals particularly in severe cases of clinical mastitis, gram-negative cases of mastitis, has very positive effects. And a very good review from the Finnish group a couple of years ago reviewed all the data and concluded that the non-steroidals did elevate the clinical signs associated with E. coli mastitis, and that the data for using non-steroidals was stronger than for using glucocorticoids. And basically concluding that non-steroidals were the drugs of choice for, in this case, severe gram-negative mastitis cases. And I don't think there would be anybody in this room who would really argue with that conclusion. But as we all know, mastitis comes in a variety of severity. So we have subclinical mastitis where there's no visual signs, no heat, no swelling, no changes in the milk, and we can only diagnose this with somatic cell count or indirect tests. But moving to cows that have mild signs of clinical mastitis, so basically changes in the milk but relatively no changes in the udder or the cow, moderate cases where the milk's certainly changed but we're starting to see heat and swelling in the mammary gland itself, but the cow's still all right up to these severe cases where there's clearly local and systemic signs. And to pinch some of the North American data, to put that in context, in fact, nearly half the clinical cases fall into this mild category, a bit over a third in the moderate category, and only about 15% in this particular US study showed signs of severe mastitis. So with these severe cases, yes, we should treat them with non-steroidal, there's no doubt about that. But The real question is there any benefit of using non-steroidal anti-inflammatory in fact, the great majority of cases that are mild and moderate? And so that is the question that we set out to examine nearly 10 years ago. So we did a large study in New Zealand with mild to moderate cases of clinical mastitis, where every cow was in fact treated with antibiotics, with injectable penethamate, penicillin-based antibiotics, and the cows were then either treated with Metacam or with the placebo, with the vehicle. And this study was triple-blinded. None of us knew which vial was which. The treatment and the control vial looked identical, and they just had a number code on them. And what we showed in this particular study was that the somatic cell count at the affected quarter level was significantly lower in the meloxicam, Metacam treated quarters here in blue compared to the control treated quarters, placebo treated quarters in green. And this effect continued out to nearly 21 days post-treatment. So clearly use of non-steroidals reduced inflammation, reduced cell count in these udders. What this study also showed us was that treatment with Metacam reduced the chance that animals were actually culled or removed from the herd. So what we have up the y-axis is a cumulative proportion of all the enrolled cows that were removed over time, and this is the weeks of lactation. So we enrolled them back in early lactation, and this is the end of lactation. And what you can see is that only 16% of the animals treated with Metacam were removed during that lactation or at the end of lactation, compared to 28% in the control group. And this is a highly significant difference. So use of Metacam reduced the risk that animals were removed, culled from the herd. And when we looked in a little bit more detail as to the reasons that these animals removed, and these are producer, farmer reported reason, one thing that really stood out for us was, and the numbers are small, but if we look here that 8 of the meloxicam treated cows were removed because they failed to get pregnant, they were empty at the end of the breeding program, compared to 20 in the control cow. So about 2.5 times the risk that a control animal would be removed for failing to get pregnant. Now, one of the limitations of this particular study was that it was not set up to be a fertility study. It was set up to be a mastitis study. And when we saw these results, unfortunately, we didn't have the data to go back and say, why did these cows fail to conceive? Was it because they did not express estrus and hence they were not bred? Or did they get bred and get pregnant or not conceive? Did they get bred, conceive, and then abort? And we just couldn't answer that question. So we then ran a second study. This one was based in Europe, and I was lucky enough to work with 10 veterinarians around Europe, many of whom are mentioned here. And we were able to run a study where we were focusing on the fertility outcomes of clinical mastitis cases. In this study, the farmer, producer, rang the veterinarian who went out, assessed the cow, so looked at the clinical signs, CMT score, clot score, dehydration score, took a rectal temperature, sampled the animal, and then commenced the treatment. And all animals were treated with intrauterine infusion of antibiotics, ubrelexin for 2 to 4 treatments, and then each cow received either the treatment, the Metacam, or the control, the placebo. And again, this was triple-blinded. The vials were literally numerically numbered, and the vet just picked up, vial 1, vial 2, vial 3, and none of us had an idea what the treatments were until the end of the study. The veterinarian and the farmer completed the treatment course, and then the veterinarian revisited the animal 14 and 21 days later, reassessed the cow, did a CMT test, looked at the animal, and took milk sample for microbiology. The producers, the herd owners, then bred the cows as per normal farm practice, whatever that might have been, and the veterinarians undertook pregnancy diagnosis. And all of this data was captured electronically for later analysis. one of the first things we found was that treatment with meloxicam, as well as the intramammary antibiotics, increased the bacteriological cure rate compared to antibiotics and no non-steroidal to the control cows. There's about a 15% difference in conception rate there. And this was a really clear, significant effect. It's not necessarily what we expected, but there you are, that's the data. And what we believe may be happening is that by reducing the degree of inflammation, we may be getting better distribution of the drug and achieving higher drug concentration in the tissue and hence better cure rate. In terms of the fertility outcome, we analysed a number of key performance indicators. So the meloxicam group are here represented in the blue and the control in the green. And just to quickly walk you through this, if we look at conception rate to the first insemination, there was 75 of the meloxicam cows conceived to that first breeding out of a total of 225 cows. So the proportion's 0.33, or 33% of cows conceived. And in comparison, the control group, 51 of the 217 conceived, or 24%. And at a very simple statistical level, bivariate level, that is significant. So just getting into a bit more detail, if we looked at the interval from calving to first insemination using survival analysis, there was no difference between the treatment and control group. So if we start here at the time of calving, day 0, 100% of the cows have not been bred. And as we pass the voluntary wait period here, cows start to be bred. So half the cows were bred roughly at about 77 days. And in fact, there's no difference in the median days, the middle cow being bred between the control and the treatment group at about 77, 78 days. And similarly, when we look at the proportion of cows bred within 21 days after the voluntary wait period, there's no difference here. About half of the cows were bred in that first 21 days of the breeding program. Turning back to conception to first service, in the final statistical model, the multivariate model now, again, we've confirmed that the Metacam-treated cows had a significantly higher conception rate than the control cows. So this is 31% versus 20%, and this is a highly significant difference. The conception rate to second and third services were numerically higher in the Metacam group, the control group, but because of numbers, that was not significant. If we look at the number of inseminations required for cows in the meloxicam group versus the control group, what we can see is more of the meloxicam-treated cows had a single insemination, so 39% of the meloxicam cows only had one insemination and they conceived, compared to 26% in the control. And conversely, only 19% of the meloxicam-treated cows were repeat breeders, required 4 or more insemination compared to 32% in the control cow. And so if we then calculate the number of inseminations required for successful conception, there were 2.46 services required in the meloxicam cows compared to 2.7 in the control group. And this is significant. So we're reducing semen usage because we've got a better conception rate. And this translates through to more cows being pregnant by 120 days into the breeding program. So this is calving to 120 days, and 40% of the meloxicam group were pregnant compared to 31 control group, and this is highly significant. And by 200 days, 61% of the meloxicam cows were pregnant compared to 56 in the control group. Not significant because of numbers. Another way of looking at the same data is the survival data. So again, at calving, 100% or proportion of 1 are not pregnant. And as cows start to get pregnant, the number of non-pregnant cows declines. And what you can see is that the meloxicam treated group, Metacam treated group here in blue, the line declines more quickly than the control group. So this is telling us that the Metacam cows are getting pregnant more quickly than the control cows. And that translates through to the middle cow in the Metacam group getting pregnant by 132 days compared to 154 days in the control group. So there's more than a 3-week difference in the calving to conception interval between the groups. So the next question is, well, is it economic? I hope I've convinced you that there are some biological benefits in treating these mild to moderate cases, but is it economic? Obviously, we're using more treatment, so there is an increase in cost. So working with some very clever economists based in the Netherlands, we did some work looking at the economics of use of Medicam. And what the team did was use a dynamic stochastic model. And just to explain what that means is that we start here with a cow and we look at her life on a weekly basis. So every week we look at the cow and say, has she started showing estrus and ovulation? Has she got mastitis this week or next week or the week after? And we also looked at the milk production every week for this cow. So each cow, in fact, was randomly drawn from a population of cows with different ages, with different milk yields, so high, medium and low milk yield, with different probability of getting mastitis this week or next week or the week after. So by randomly running 50,000 cows, which is what we did, so by selecting a cow and running it through the model and then doing that 50,000 times, you get a very good idea of what the average production, reproduction and mastitis outcomes are for that animal. And so the model was run with standard antibiotic treatment but no Medicam, and some numbers were generated in terms of milk production and reproduction outcomes and so on. And then the model was run 50,000 times again, where all the mastitis cows were treated with Medicam. And by looking at the difference in both the biology, the milk production and the reproduction, we can then start putting economic numbers on it. So just to very quickly summarise it, what the model said was that the net economic benefit of treating a mild to moderate case of mastitis with Medicam compared to not treating it with Medicam was about €42 per clinical mastitis case per cow per year, or $49 or about 5,500 yen. And by doing what's called sensitivity analysis, by changing the model parameters, so looking at high, medium and low production, looking at poor or good estrus detection rates on the herd, by varying the voluntary wait period from 50 days to 60 days to 70 days and so on, and also varying the cost of production, the cost of feed, the milk price, AI costs, and the culling costs, the retention payoff costs. The model showed us that the return, the net present value of using meloxicam, Medicam, was positive over a very wide range of biological and economic situations. So we're very confident that in just about any dairy industry in the world, this will hold true. It will be cost effective to use Medicam in these mild to moderate cases. So to try and summarise a lot of data, the point is that mastitis is certainly a local disease. We see it in the mammary gland, we see changes in milk, we see changes in the udder, but it's also a systemic disease. It also has impacts on the rest of the body. We see increase in temperature, we see reduced feed intake, reduced rumination, and as I've shown you, negative impacts on the fertility of those animals. Prostaglandins are part of that inflammatory response. They're one of the key molecules that are involved in this inflammatory response. But as I said earlier on, if inflammation is excessive, if it's causing tissue damage for a prolonged period of time, there are negative consequences of that. And particularly where we're using antibiotics to help deal with the bacteria, managing the inflammatory response may be important for biological outcomes. And so we know, and there's lots of data to show, that non-steroidal anti-inflammatories reduce edema, pain, pyrexia, reduce heart rate, and minimise the feed intake depression that we see with mastitis. And the studies that we and others have done show that use of Metacam reduces somatic cell count in clinical cases, increases bacteriological cure proportion, increases first service conception proportion, increases the proportion of cows pregnant by 120 days. Cows get pregnant more quickly by about 3 weeks, reduces the amount of AI we have to do, semen doses, and reduces culling risk. And the economic analysis is reasonably robust, showing us that there's an economic return of doing that. So really my final message is that the data we've got says that we should be using non-steroidals, and the evidence is there, particularly for Metacam, in both our severe cases of mastitis, which I think most people would do now, but also showing that use of Metacam in these mild to moderate cases does have biological benefits, welfare benefits for the cow, production, and has improves fertility and has an economic positive effect for the farmer. And so with that, I would like to stop and thank you for your participation, and again just acknowledge Boehringer, who helped fund a number of these studies. So thank you very much.